Hi, my name is Taruz. I'm a plastic surgical trainee from the UK, and I'm part of the BFIRST charity. It's my pleasure to introduce Mr. Young Singh. He's a consultant plastic surgeon at the Sheffield Children's NHS Trust in the UK, and he's worked with numerous of plastic surgery units in England, and is particularly passionate about expanding training opportunities in the specialty at global scale. He's facilitated the development of a microsurgery unit in England, as well as he's currently establishing the microsurgery and reconstructive services for Trinidad and Tobago. I'll give it to Mr. Young Singh to start the talk on free tissue transfer in low resource settings.
Hi, so I'm just going to share my screen and just some housekeeping. I'm pretty happy to be interrupted. Um, if any questions, just raise your hand and I guess we'll get it. Um, and so one thing I would say is that it's really easy to look at a free tissue transfer and they're complex operations. It's easy to look at the gold standard and say this is what we need. But when you're in a lower resource setting, you don't always have all of those things. And so must be able to adapt and you must have to understand that there are ways to adapt. It's not always the right way, it's not always the best way. But when you're in that situation, you just need to know that there are options and thought processes. I don't have any disclaimers. I think the objectives are to understand how to implement it, how to adapt, and how to enhance any outcomes given your setting. You want to look at some factors. Is it feasible? Is there a proper mindset? And is there equipment? With regards to feasibility, a lot of people would say, well, how do I do a free tissue transfer in a low resource setting? And I'll get to that. In terms of mindset, you have to understand if you're not doing an operation where there's never been done before or very little of it, people may not understand that. Other surgical specialties may not understand that. The nurses don't understand that. Juniors, consultant colleagues, they won't understand that. Even management, what hospital staff won't. So that's something that's going to have to be worked around. And equipment, in low resources, it's easy to say get some micro instruments, but you will have to modify. And I have a little sign there that says you can't judge that if you're privileged, but only from those in the setting that are placed in that setting can judge that. Um, and how do we assess the feasibility? Well, you want to assess operations with similar operating times, okay? And that gives you an idea if you can do it, it's capable, and if your staff is actually willing to do it. So some operations that take 8 hours, 12 hours, if you're doing operations like that, you have the staff for this. This would be maybe possible. You also need to get some approvals from head of departments, head of theatres, your chief of staff, anesthesia heads. In the UK, we tend to call that a multidisciplinary meeting. That may not be a structure set up for everyone, but what you want to do is get as many people on board who will be participating in the patient care, and that tends to give a unified approach and a better outcome. So that's what you try to aim. And it can be informal, it doesn't have to be as formal, but all documented. And that way you get as much help as possible. Post-op monitoring. In lower settings, I appreciate there's not enough nurses or junior staff. And so you have to consider options. I mean, I have considered using HU beds and I have used them and ICU beds. That used to be the way when we first started doing free flaps. And as free flaps became more and more of a routine, it became where you can move them to a ward where the nurses are trained. Even consider using juniors. Even now, I still monitor my patients for at least 2, 3 hours after. Um, you just have to figure out what to do. What I will say is that monitoring post-operatively has moved complications and success from 70% to up to 90 something percent. So there's a significant gap. If you can't have it, you have to understand though that you're going to have a possible 70% failure even at optimum settings. So just bear that in mind. And I would say if you're doing a low resource country or low resource setting, you might even have a higher failure rate simply because you don't have body factors. So you have to understand and appreciate that. I think the mindset is really simple. If you have a drive to it and you want to do it, you will find a way. You do have to understand that not everyone will share that same passion, goal, or mindset as you. Um, Failures, There's many people who have tried. You could quote Edison, you could quote Bunk in our world. Bunk did many total jump transfers in his garage um, with his wife, who was a dermatologist who helped him until he got it. Now he's one of the biggest units when they established it. That time, everyone thought he was a bit crazy. He couldn't go to Japan at the time to learn his microsurgery. He did have to eventually. Um, I think looking back at your work, when you do it, you need to assess it, always rehash it, and always don't be afraid to always look back and think, what could I do to fine tune it and make it better? And lastly, you always have to remember the patient is at the center of all of this. Patients in some settings may not have ever heard of the operation, seen the operation. Now we have internet and you can Google this. You can, look it up. You can show them photos. They will probably have Googled it, but you still need to appreciate that they may think, are you doing something to me that we've never done before in this country? It's quite difficult to grasp for them. And you have to explain it into a way that they understand and be very open about it because you may not have all the successes. I don't, but you have to be open that look, this is a try in what with what we have at the best possible outcome that we know. And so it's easy to quote figures from Japan or Taiwan about success rates of, 99% or 98%, but that may not necessarily be the country that you're in. And so you have to remember that it's a local setting. Um, Equipment. I think this is probably what is the hardest thing in a resort setting to work your head around when you're sitting down there. The best suture I've found so far, or the most versatile one, is a Nino, Ethalon, or Proline. Ethalon is more expensive because it's just a brand name. You just want the Nino on the needle, really. Um, the needle is the biggest factor simply because it's what helps you to navigate the lumen, um, and it has just enough strength. You want a 5 millimeter needle ideally to start off with because if you're going to try with a smaller needle, which is 3 point needle, um, it tends to bend quite easily, and you need a very fine needle holding forceps for those, which you might not have. And normally, what would happen is that you would either get someone to bring it from a country that has it. The average cost is about 200 UK pounds for a box of 12, but by the time import costs would kick in, you may be paying a lot more. I do note there that there are cheaper in some countries, for example, India. Japan has good sutures, but they're very far away, and the import taxes for both do tend to spike the price. And then what would you think if you don't have it? And I've been in that situation a few times. You want to get a round bodied Ethalon. 6.0 is a large needle, but with your upper creek and you really need to do anastomosis, if the lumen is bigger than 1 to 2 millimeters, it may be possible. You just have to be really, really careful of catching the back wall. You have to know that there's a higher risk of anastomotic failure. There's more suture material in the lumen. And I would say that, as long as you have a high flow anastomosis, it may be possible. And I would put some considerations there. Do a mattress suture, distance evert the suture, the edges of the anastomosis and leaves less suture material in because it's so everted. And also try using a larger vessel. Take a parent vessel if you need to, or take a cuff and even a segment of the parent vessel and repair the parent vessel directly as a patch or with a vein graft. I have done this for, like, for example, MSAP, where if I know the leg has a 3 vessel runoff, I take the tibial artery as part of it, and that gives me a bigger size to anastomose. It is a bit difficult to wrap your head around, but I'll show you um, what it looks like in a sense in diagrammatics. So, for example, here you have a femoral artery, and this is technically a SCIA, and you take a part of it as a cuff, and you can actually repair that either primarily or with a patch, and that's the metal, and they tend to use that for smaller perforators. That's for the artery. In regards to the vein, what would you do if you come with the vein too small and you're thinking, well, look, it's very difficult for me to do this because limited equipment, limited scope, limited magnification. I would say if you could harvest a parent vein, not just a pedicle, tiny parent vein, the body is quite forgiving of venous drainage. There's deep and superficial supplies for both, and most times there's no morbidity. I'd always say also in a setting in a low resource, always try to have a superficial vein coming from your flap. And that does help to drain your flap because those are technically always bigger, sometimes on your pedicle. And consider anastomotic techniques. I've put one here for side-to-side anastomosis, and that can be done. Vascular surgeons do this all the time with 6-0 proline. So I'm showing you one with 9-0 suture, but this can be used to compensate for larger vessels to anastomose them if you're not in the optimum equipment setting. Well, to if you don't have a microscope, microscopes are expensive if you buy the fancy ones. If you look at a cheap microscope that can be used clinically, the price you get it for is about 4,000 US. And those are normally optal microscopes. And you have to get one with a 120 to 90 degree arc. You do have to bear in mind, though, that they have fixed focal lengths. And I have tried this before. You can use them for hand and maybe lower legs, but it's very difficult for the chest or head and neck simply because the focal length is so short. You can use an ENT microscope sometimes, but just bear in mind most ENT microscopes tend to be 180 degrees. And if you get that one, you can use that one for head and neck. If you're lucky enough to get one that rotates you 120 to 90, that is a winner. But limb ones with 180 is very, very difficult. And for loops, you can use a 3.5 loops. There's a number of papers and stuff that corroborate this. Most of them come out of the US. And if you get a 3.5, you can do most anastomoses with it. I wouldn't say it's optimum, but you can use that. For example, this is female done in 2015. She had a necrotic area over the knee. This was a free lat dorsi that was done via loops with a skin graft on top of it. She's now how many years down the line, and it's all fine. But these are things that you have to consider. If you have a microscope, you have better visualization, better optics. Flap choices. If you are going to do it in a low resource setting, and using a suboptimal suture, like I said, try to use anything with a 1 to 2 millimeter arterial diameter. A lot of flaps have that. For example, your radial artery, dorsalis pedis. Your ALT may have it, but sometimes your ALT, the venous pedicle, may be small. Fibula is also possible. Again, venous pedicle may be small. And lat dorsi, again, venous may be small, but large artery. These are more reliable. I tend to prefer fasciocutaneous flaps because often in a limited resource, you don't always have a salvage theater or a theater that you can get back in quite quickly because you're always sharing it with a number of other specialties. So you're in a long time. So I tend to do the fasciocutaneous as the ischemia time can be a bit more withstanding, albeit the clot propagates. So it's still not ideal, but it does last longer than muscle, which is only 2 hours, and you have no chance of salvage after that. In terms of instruments, you're looking at clamps. Well, if you're using a large vessel like 2 millimeters, you can use a build-out clamp from vascular. I don't recommend it if it's arteriosclerotic, but if you do have to use those, clamp as far away as possible, expose the vessels further up and get it. I do use vessel sloop sometimes. I've given a little diagram there of how to use a sloop, and it's quite easy to use. If not, you can use the finger of a glove if you don't have these fancy sloops. And you do have to have an assistant pull on it sometimes. If you're you might get a little bit techy and use an artery forceps and pull on it gently with not too much tension. You will end up doing a wet anastomosis most times, though, if you use this. And so you have to have a lot of hep saline or saline to help you see the lumen. If you're doing limb recon, I have used tourniquets instead of these. I just let down the tourniquet, check the proximal flow, examine the hand again or limb, and then reapply the tourniquet. I actually like it. It's not that bad. I have used Eshma and Crep if there's no tourniquet. I know it's not ideal because you don't have a pressure setting. You can't measure how much millimeters of mercury, but if you use some gauze, large ganji to distribute the pressure, is fairly safe. You can't apply more than 200 millimeters of mercury with your hand, even if you were one of the strongest guys in the world. Um, Instruments. This is also a very expensive part of it. Micro instruments can be expensive depending on where you order it from. If it goes to a distributor, normally the cheapest way to obtain your instruments is to go yourself, get it from a country and bring it back. Conferences are cheap. You can order them cheaply from manufacturers in Pakistan, India. It's the same level of surgical grade steel as most German instruments. German instruments do a CE quality stamp on it. Surgical grade means that it's corrosion resistant, and you want to have at least a 630 steel grading or 613, and that's just the number of chromium in it to prevent it from rusting. What you do want is a needle holder, ideally a dilator with a 1 millimeter tip, if you can get it, because it's most versatile. Some two jewelers, and if you can't get a microvascular set, you can get an ophthalmic set, which are titanium lighter, but I don't have a dilator for obvious reasons. Optal does not do vascular work. I'll get to what to do if you don't have a dilator. In terms of needle holes, if you can't get micro instruments, a Castro is what vascular surgeons use. If you are in a hospital with vascular, use it. You can use it. They're a bit clunky. Sometimes they may be locking, so you have to be comfortable with the locking and unlocking feature. It does hold up to 7/0 quite easily. You may get with it with an 8/0 for the needle, but 9/0 is a bit of a push. Of course, the 6/0 works fine because vascular uses 6/0 all the time. I have filed Castro tips to make them thinner because that's what makes it clunky. I will also say that they don't necessarily hold the suture of a 8/0 or 9/0 very well all the time when you're tying sutures. So you may want to use your forceps to do that if you have those. A lot of people talk about microvascular instruments, but DeBakey's are an important part, I think, of when you're handling vessels. Vascular tend to have it. If you don't have it, I have used an on-tooth forceps, but I would caution just to hold only the adventitia. Again, micro scissors and even scissors, you have no tenotomy sometimes. I have used Mackindos and I have fine artery forceps to dissect around the pedicle or small mosquito. A lot of countries use this. You don't need to have tenotomies. We're quite lucky and fortunate in other countries to have tenotomies, but these tend to work fine. Micro scissors, 11 blade and pots, if you don't have them. They work quite well, and you really just need them to get a good clean cut and to vent the anastomosis if necessary. In terms of Liger clips, well, Liger clips are those things that you use to close off small vessels or larger vessels. They make it a lot easier for us. But if you don't have those to tie off the vessels, again, good old suture ties for larger vessels. And I have done this for fibulas. It's painfully slow. You can use a bipolar. Ideally, if you could get a non-stick bipolar, it would be better because if it is one that is not Teflon coated, it tends to build a lot of carbon deposits and spread heat even more. And actually, it's worse. Traditionally, thinking is that bipolar is safer because it's a finer controlled setting. However, if you listen to Borchell in Canada, he uses his monopolar for it. I have another in JP Hung in Korea uses monopolar to raise, and actually they actually think that this is fine. They are masters of the art. I think it should be fine. Dilators. So let's say you've got an optal set and you don't have the dilators or you just don't have them at all. There's actually no need to dilate. Really, dilation is really to allow you the needle to pass easily and to help you manage any anatomotic differences in terms of mismatch. If you can judge the mismatch, I actually think that dilating a damaged vessel is actually worse than doing anastomosis without it. If you do have a 2 millimeter vessel, you don't need to dilate it. If you do want to dilate a 1 millimeter vessel, you could use the tip of a needle holder or Castro if you don't have a dilator. Anything less than 0.8, which is actually microsurgery, you can use the back of a 0 Etalon suture. Anything less than 0.5 all the way to 0.2, the back of a 5/0 suture. And what you do is you cut the piece of the suture with the 11 blade so that you prevent it from having sharp edges or pointy edges. And if you can pass that very gently into the lumen, you basically can pass the needle. The 5/0 suture is equivalent to a 9/0 needle. With the 0 suture is equivalent to an 8/0 and a 6/0 sometimes, depending if you get a small needle. And the 1 and 2 millimeter, I don't consider that microsurgery. It's actually still just vascular surgery. And most flaps are actually 1 millimeter that you would be trying or doing in a low resource setting. Heparin saline. It's ideal if you have it. I do appreciate you don't always have heparin. So what I would suggest is always get either the saline or the heparin and flush the flap from the artery as soon as you disconnect it as much as possible. Saline does move clots. You just need to move before the clotting time of 8 minutes to allow that until you can see clear venous flow run off. Some people flush their flap, some people don't. But then if you don't do it within the 8 minutes, you need the heparin to break up the clot, and that's where the heparin comes into play. But if you flush all of the vasculature with saline before 8 minutes, when you detach a flap, it's not necessary. I will say detach only when your recipient or proximal vessels are ready, and that just cuts down your ischemia time and helps, you know. Bear in mind that there's no salvage theater always dedicated to going back with a free flap, and you may be sharing with a lot of other specialties. I tend to advise to take time to close slowly after you've done your anastomosis. Take at least 45 minutes to, you know, insert your flap and close donor sides. And most times by then, if the artery would have clotted, you'll know, and you can then redo it if necessary. But I felt if it's crossed 45 minutes, you can probably breathe a bit easier. And then you worry about the vein that normally gives trouble at day 3. In terms of monitoring, you're gonna have to train either your nurses, junior, or do it yourself, or accept that there's no salvage, because there's no one to raise the alarm. I know that sounds a bit sacrilegious to say, but that is a reality of the situation if you don't have it. Most times you might not have a Doppler to monitor, and I would say clinical is fairly accurate. It's still the most popular approach, and it is a preferred method. There's lots of evidence to show that it is reliable. I will say that taking into account higher Fitzpatrick types, for example, brown or darker colors skin, you don't see a pink, warm turgor or capillary fill. So I tend to use a scratch test, and that's quite easy. Bright red blood means it's good. Purple or no blood is very bad. Purple meaning congested, and no blood means there's no inflow. I suggest when you do this in a setting that's not familiar with it, always do it on the table as you've done your osmosis, video it with a phone, use the light, and use always the same phone or the same light because it tends to look different under each light. And use that video for comparison. It helps with the teaching of anyone who's monitoring the flap. It helps them to understand it, and it's always good for reference. I will say if you do a darker Fitzpatrick type, for example, in the Caribbean, we have multi-ethnicities. You will see some ethnic types have a darker red hemoglobin blood, even though it's well vascularized. And so you need to see that as you've done your anastomosis to understand that that is the color, as you may be fooled thinking that it's congested. Um, in terms of, sorry, in terms of avoiding, a second, in terms of avoiding, bear with me. Yeah. In terms of avoiding problems, if you don't have a salvage theater, you try to do as many things as possible to prevent having your flap to fail. And very simple things are considering leaving large gaps for your hematomas to drain. I tend to use a finger of a glove if you don't have any corrugated drains. This just lets everything drain out and you don't have to worry about hematomas compressing on your pedicle. I would also say consider doing some delayed primary tension sutures. Ming Wei does this in Taiwan. especially for his lymphedema flaps. He just basically ties the suture with a mattress stitch and then steri strips it, but doesn't actually cinch it down. He lets the flap swell, and then slowly after day 3 to day 5, he slowly tightens it to close the epithelial edges, and that just prevents congestion while the flap is settling. I think this is a good idea for in a low resource setting, and I have done it. I tend to leave it quite loose. The only downside to it is that if you have any bleeding, it will have a lot of oozing. So just warn the nurses and warn the team that you expect this, and you may need to have some blood transfusion if that's the case, if it is a bit too much. I've also used an IV cannula in a superficial vein. This is normally where you raise the flap with a superficial vein, you tunnel it subcutaneously, and you heparinize it with a Venflon or an angiocat. And if the flap congests, you can actually use it to drain the flap to help the congestion if you don't have leeches. I appreciate that's difficult to get. And if you can't get back to theatre, then you have to go until day 14 when the flap starts to automize. They tend to automize from day 14 to day 17. And then you may have some partial flap necrosis, which you'll have to accept and deal with. And you just have to bear in mind that if you're going to do this method, you will need a blood transfusion. But it is the same with leeches anyway. And Mingwei also does this for his submental flaps. I just suggest a photo showing a free radial forearm that was done in St. Andrews. It's an elderly patient. She was quite comorbid at the time. Resected the tumor, resected the plate. Flap became congested on day 3, and at that time she was a bit too unstable to go back. Anesthesia was not keen on taking her back. We did have leeches, but we had a shortage of leeches, and so even though we didn't tunnel a vein, because that's not normally done in a high resource setting, um, uh, we just use an angiocat into the congested vein that you can see on the left, um, put some heparin in it, and you can see the blood coming out of the angiocat on the picture in the right, and you can see that the flap is actually changed. Interestingly, where the leech is sucking is bruised and still very purple, but this does well. We did that until she was automized, and actually it was fine. At that time when we did it, everyone was a bit concerned until they saw the publication of tunneling the vein. But this is a well-documented technique, and I think it should be used, especially if you don't have a salvage theatre. In terms of if it's congested again, you can also scratch with heparin soaks or alcohol wipes if you don't have heparin. Alcohol is a vasodilator. It doesn't stop the clotting, but it does help it to bleed quite a bit, and it doesn't infect your wound. These are normally used for fingertips. I wouldn't really say that would work for a large flap. And obviously, the ideal would always be to get back to salvage if it's congested. But if you can't, and there's no way, then you're just gonna have to rely on what's called Crane's principle, and hopefully a vascularized bed will be left behind. So leave it, let it eschar, and then debride off the eschar skin once it lifts 6 weeks down the line, if you can, once it's not infected, and graft on that if you can, or do another salvage flap. But just a little thinking process. If you need salvage, you need salvage. If you can't, then you have to consider regional options. This is quite commonly done, especially for head and neck surgeons. There's always like pec major, lat dorsi, delta pecs. And if you can't do a regional option, just remember still that if you have had Crane's principle, you could still do dressings. You could still have do vacs. If you don't have a vac, which is an expensive vacuum machine, while it's frowned upon in more developed countries, wall suction is always a thing. And if you want a more controlled setting, sometimes cardiothoracics have chest tube suctions that can be tapered to the millimeters of mercury that you want. And they're still your friends, so you need to remember that. Just because you don't have a vac, you can still use all of these things. In terms of dressings, you don't really need anything fancy. You really just want to keep the flap warm. If you're in a tropical or warm country, you don't need dressings much. You can consider no dressings. Um, I've seen surgeons not use any as long as you have good hemostasis. And just remember, in terms of like open wounds or donor sites in other environments, pseudomonas is a higher problem in warm climates. Um, when I do a flap or I take from donor site and I put a skin graft, it's going to get pseudomonas if it's warm and humid. And so I just use a simple gauze soaked in paraffin oil to create a non-stick. And then I layer that with another gauze in 1% acetic acid. And that tends to hold the pseudomonas at bay. The key to decreasing that is regular changing. The ideal would be to change daily, but I appreciate that that may not necessarily be done, but as often as possible to decrease pseudomonas. Um, in terms of training, there's a variety of different ways to train yourself if you're from a low resource setting. Um, Bear in mind, chicken thighs are 1 millimeter vessels and chicken wings are zero point 0.5 to zero point 0.8 rabbit ears have been used. I will say do not use the video microscopes that they sell online. Just get a proper laboratory-based microscope or a training microscope if you can. Video microscopes don't give you any depth perception at all, but the lab-based ones do. And that'll probably be cheapest bet. Just bear in mind there are differences if you are doing this in a resource setting. To illustrate that, I'll show you the thickness of a skin paddle for a 13-year-old child in one country. And you can see it by the blue line there with the circle. That's just fat, that's just skin and fat. And if you look at, for example, the fibular paddle for a Welsh male individual on the right side, it's just a dot. And I mean, this is it's a significant difference. And if I were to show you Asian, it would be even thinner than that. There are possibilities. You can do operations, for example, distal tip replantation. I've done this with a 10 millimeter, sorry, 10 times zoom microscope with microsutures and scratch it for 5 days because there's no vein. You know, I use the 5 protein as a dilator here, and this is 3 months post-op. It's quite possible you don't need a super microscope. It's just a video showing a pre-submental. That's been done with a 10 microscope, 10 times zoom microscope as well. It's only 4 months, but you can see the swelling decreasing. This is what the patient took on the right-hand side themselves, but lymphedema is getting better. I did use a separate anterior jugular vein to drain the flap to the long staff, and that's a big vessels that you can use 6O if necessary. It's free joints, same time, 10 times zoom microscope. I didn't use any clamps. I just used foot and arm tourniquets. And that is also a possibility. It's a large dorsalis pedis, it's a large artery, and you have large superficial veins. And that lends to the same thing as almost the dorsalis pedis flap, really. And yeah, I just would say that it's always better to try and fail than fail to try. And it's easy for everyone who's experienced a gold standard to say a lot. But when you're sitting down there by yourself and with no resources or minimal, you know, you're in that situation yourself and you need to figure it out. So don't worry about the critics too much. And that's my presentation. Any questions?
Thank you so much for that talk, Mr. Youngsing. That was really fantastic and super interesting. If anyone has any questions, do use the raise hand button at the bottom, or you can type it in the Q&A. We'll wait for a few more moments. It seems like you've done a fantastic job at answering everyone's questions in the talk. If people want to reach out to you maybe for some advice, is that possible? Do you have
Yeah,
contact
yeah,
number or anything?
you could do that. Qyoungsing at Gmail, Youngsing, no spaces, at Gmail. Qyoungsing at Gmail. And just pitch me an email, and I'll be happy to help or assist in any way possible. Always open.
Great. Thank you so much for that talk, Mr. Young Singh, and thank you for everyone for taking that time out on your Saturday to attend the talk. Of course, this is part of a webinar series, so keep an eye out for future talks. And you've obviously got Mr. Young Singh's email address if you want to contact him personally. Okay, have a good weekend, everyone.